Hi, and welcome back to MedTutes. Today we're going to cover shock and the different types of shock. It's a broad topic and I'll try and break it down and make it as easy as we can. To start off with, what is shock? Shock is a term that's thrown around a lot in medicine, and when you're first entering the field it can be really hard to get your head around what on earth they're talking about. Shock isn't just, someone's had something really disastrous happen and people say they're going into shock kind of thing. Psychological shock is a very different thing to what we're talking about today. Today we're talking about physiological shock. So that's the first distinction to make. So psychological shock is when someone encounters something traumatic, and it's a coping mechanism often to help with that. And the psychological trauma can often cause a physiological response. But what we're talking about today is purely physiological. And what we're talking about really when we talk about shock is a state of poor end organ perfusion. So shock means poor end organ perfusion. What does poor end organ perfusion mean? Well, you can think of it in a few different ways. Basically, it means that your end organs, so your important organs, aren't getting the blood that they need. And by not getting blood, they're not getting oxygen, they're not getting glucose, and they're also not removing wastes. This can be a broad term to kind of think about, so let's break it down to a few easy things. So the brain is one of the end organs. And what happens if you stop supplying the brain? You get confusion and a drop in your GCS. So when I say that, Glasgow coma scale, so it's a drop in your conscious state, essentially. When your brain isn't getting perfused, you get confused and you drop your conscious state. Kidneys are the other big one. So when you stop perfusing them, you get an AKI. And how do we measure AKI? You measure it with a UEC. So you get increasing urea, increasing creatinine. You can also get electrolyte abnormalities, which is what the E is. Other things that can be affected, your liver, in which case you get LFTs derangement. So your liver function tests become deranged, and that presents as, raised ALT, AST. Predominantly a transaminitis. You also get the raised GGT and ALP as well, though. Predominantly this kind of thing, though. They're the big kind of things that you'll see. You'll also get, in most of these cases, you'll get a raised lactate. I'm going to discuss lactate a little bit later when we talk about different types of shock, but just, I guess I should break this down to current kind of teaching and current thinking and where the field is heading at the moment as well. So under current kind of doctrine, current teaching, the raised lactate is because when you have the poor end organ perfusion, you switch to anaerobic metabolism, and the product of anaerobic metabolism is lactate and lactic acid. You heard me pause before and try and divide this up. The reason that I'm trying to make this distinction is that when we talk about shock is often a kind of a clinical diagnosis. It's a sign that someone's really sick, but we've tried to assign different values to it and different objective measurements. So blood tests we can do, things that we can test for, such as lactate, that give us a score that tells us how sick someone is. Because we're trying to find markers and objective phenomena to classify what many consider to be a clinical presentation, there's a lot of debate and the space is very labile, so it's moving constantly. And so an example of this is with lactate, and I'll touch on this again a bit later. We originally used to think that it was a sign of poor end organ perfusion because of its production in anaerobic metabolism, but there is some evidence to suggest that it may be playing a different role, and I'll come back to that. So I guess the purpose of this tute, everything I think when you're going through med school, you need to learn the things that will help you pass your exams, and you also need to keep in mind the way that the field is changing. So the ways that the field is changing may not necessarily be reflected in what you have to answer for an exam. And so in an exam, they want to hear you say that lactate is due to anaerobic metabolism. It's a sign of poor end organ perfusion. But as I'll touch on again a bit later, I'm kind of alluding to it a lot, the field is changing the way it perceives this. But anyway, that's what shock is. So shock, basically you're thinking poor end organ perfusion. And we use a variety of different kind of physiological markers, predominantly based on the vital signs. The reason they're called vital signs is because they're vital. These are the things that are really, really important to live. So they're like rest rate, heart rate, blood pressure, oxygen saturation. These are kind of the big four. You can also include things like GCS. You can do things like blood sugar levels. And you can incorporate a few other things into this, but really the four key ones are rest rate, heart rate, blood pressure, and oxygen saturation. And so different studies and different hospitals and different clinics, all these kinds of places have different policies on what will classify someone as being in shock. So again, it's people trying to put physiological boundaries in place to try and explain what is largely and predominantly a clinical phenomenon. Great. So that's shock as an overview. Now let's talk about the different types of shock. And there's a mnemonic you can use called SHOCAN. SHOCAN is what I use to try and classify the different types of shock. You'll hear people use, again, different classifications, and I'll broadly explain how this mnemonic fits into the other kind of descriptions of shock. So first off is septic. So shock due to infection. Hemorrhagic. Shock due to bleeding. Obstructive. So shock due to some block in the system. Cardiogenic. Something's wrong with the pump. Anaphylactic. And neurogenic. So some people will classify septic, anaphylactic, and neurogenic under one heading called distributive. And I'll explain why. If we think of the system as, you've got this bucket here, which is your venous return. You've got your heart, which is the pump. That pumps it through the arterial bucket. And then the arterial bucket drains into your venous via the end organs. Think of this as the system. In distributive shock, what we're saying is essentially this bucket blows way out. So in order for it to drain through and actually reach the end organs, it needs to fill up here first. And there's now a much greater area for it to fill before it will drain through. So maybe if I change the way I draw this, and have it so that the pipe that comes in to the end organs actually comes from the top. So if this is much bigger, it needs to fill up higher before it can start trickling down to the end organs. And that's why you get poor end organ perfusion, because in these states of distributive shock, so septic, anaphylactic, and neurogenic, you've got a bigger space to fill before your end organ perfusion gets achieved. And that's why they get poor end organ perfusion. We're going to run through what each of these different things mean, but I thought I'd just clarify that. So sometimes you'll see septic, anaphylactic, and neurogenic described as distributive shock. The reason I like to break them up is that the mechanisms behind septic, anaphylactic, and neurogenic shock are very different. And so you treat them very, very differently. So even though their mechanism of hypotension and poor end organ perfusion is the same via distributive, the way that they get there is different. Cool. So let's start with septic. Firstly, let's talk about sepsis. This kind of brings us, it's a good time maybe to chat about the difference between bacteremia, sepsis, and septic shock. Bacteremia is the presence of bacteria in the bloodstream. This doesn't necessarily mean the person is sick. So this can happen after dental procedures, after flossing, brushing your teeth, that kind of thing. And in these cases, it typically happens transiently. So bacteremia is simply the presence of bacteria in the blood. It doesn't necessarily mean that they have a clinical syndrome, that they have symptoms, anything like that. And perfectly healthy people can have transient bacteremias and not be classified as sick. Then we get to the definition of sepsis. Sepsis is where you're getting kind of systemic symptoms of illness. So you've got pyelonephritis, but what you're getting is, so you have a kidney infection, but now you're getting fevers, anorexia, hypotension, tachycardia, and tachypnea. So all these signs that, it's not just a simple infection, but you're actually getting quite sick from it. Then we say someone is septic or they have sepsis. They have kind of a systemic infection, so like kind of overwhelming systemic infection. Again, depending on where you are to determine what the criteria are for sepsis. But where I operate, the definition is a systolic blood pressure less than or equal to 100 millimeters of mercury, and a rest rate greater than 22. As a side note, rest rate is one of the best indicators of sick patients. People's rest rate, particularly in sepsis, will rise much quicker than, it will respond faster than blood pressure or heart rate. So someone's rest rate will increase before they get the drop in blood pressure or the rise in heart rate. The other thing is altered mentation. So if someone comes in and they're delirious and confused, that can be a sign that they're septic as well. You need 2 out of the 3 in order to be classified as sepsis based on where I work. And again, this will be different. The other thing I think is important to mention is that you've also got to presume, it's presumed to be an infective cause. So it doesn't need to be proven to be an infective cause, it's just presumed an infective cause. Cool. Septic shock is different though. This is kind of like the spectrum. We start at bacteremia, then we get sepsis, then we get septic shock. Septic shock, you then have a lactate greater or equal to 2 millimoles a litre. And you can get this via an ABG usually, so an arterial blood gas. Sometimes they do it via VBG, but there's different cutoffs. Sorry, so different cutoffs before other than 2 millimoles, because your lactate's naturally going to be higher in the venous blood gas as opposed to the arterial. So greater than 2 millimoles per liter on an ABG, as well as a MAP, so a mean arterial pressure less than 60. So with septic shock, you have these things here, but you also have this here. So mean arterial pressure less than 60, lactate greater than 2. So this kind of brings me into what I was talking about before. The MAP as well should be after fluid resuscitation. Because this aspect is really hotly contested and hotly debated, this whole kind of area, if we switch away now, so this is the teaching that they want you to know for your exams, and then the current situation and how the field is currently moving is this idea that these numbers are very arbitrary. And in different patient populations, these cutoffs are either going to be too lax or too strict. So people that are really young, fit and healthy might naturally have a MAP that's a little bit lower than 60. People with chronic heart failure might have a MAP lower than 60. So them being less than 60 may actually clarify them, set them as having septic shock, whereas in reality, they're actually used to operating at a lower MAP anyway. The other thing is that maybe they're too strict. So if you're a patient with chronic hypertension and your blood pressure is usually, let's say, like 170 on 110, something like that. And that's where you always start it. You've been at that for like 15 years. And now your MAP is less than 60. You are likely incredibly ill. So even though you might have the same MAP as a young fit 20-year-old healthy patient, then the actual clinical presentation is going to be much different. And that patient that's used to being chronically hypertensive, by the time they get to below 60, they can be almost dead. So this is starting to be taken with a pinch of salt, and again, not something you necessarily need to know for your exam, but it's a really good thing just to keep in mind, and it's a good way to show that medicine is an ever-changing field, and the things that we get taught today aren't necessarily the things that are going to be taught tomorrow. The other thing is this idea of lactate. So I kind of said before, it used to be thought that lactate was purely a product of anaerobic respiration, and that it was never a good thing, and it was always a bad thing, and we had to continually try and treat people to get it below 2. That idea is starting to be challenged. And again, learn this for your exam, but then keep what I'm about to tell you in the back of your mind. With a lactate greater than 2, there is actually some evidence that lactate is simply a marker of adrenergic activation. So high circulating levels of adrenaline and things like that may actually just cause lactate levels to rise. There's also potentially some evidence that lactate is actually produced intentionally by metabolic pathways in order to increase the metabolic activity of things like the heart, because the heart can use lactate and ketone bodies and things like that as an energy source. So there's evidence to suggest that maybe the body produces lactate in response to adrenaline in order to allow a greater energy source other than glucose when other cells are using glucose. So that's the current hypothesis, and I would really encourage you to do your own reading into this. But as I say, that's like a level too far for your exams. It's a little bit too close to the bleeding edge of medicine, and we need more evidence to kind of back this up before it's going to start being incorporated into clinical care. Cool. So that's septic shock. So septic shock, you've got low blood pressure, so you're hypotensive. You've got tachypnea, altered mentation with a raised lactate and a drop in MAP. That's how we, at least in my hospital in Australia, that's how we define septic shock. And again, there's different things. And what's happening, using this model here again, what's happening is your arteries are actually dilating. So you get arterial vasodilation. And you also get increased vascular permeability because you've got a very high presence of inflammatory markers. So in a similar way to anaphylaxis, as we'll talk about later on, basically what's happening is you're getting an overwhelming infection. And what that infection is doing is it's created a dysregulated inflammatory response or immune response. Which is why in these patients we often give steroids. Again, contentious, so I won't go into that. But we often give them steroids because what's happening here is that we've dysregulated our immune response and it begins to overactivate, producing lots and lots and lots of inflammatory cytokines. And the cytokines promote vasodilation and vasopermeability. So, let's use a different color there. So this is your blood in here. And now, rather than having to take up, let's say, usually the caliber of the vessels is nice and thin and the blood flows through, and the volume, so the volume is small. What's happening with the vasodilation, the caliber of the vessel has now massively increased. So the volume is much, much greater. And as we know, pressure and volume are inversely related. So a rise in volume is equal to a drop in pressure. Compounding this, so that's why you get a low blood pressure, by the way. low MAP / systolic blood pressure. Confounding this as well is this increased vascular permeability. So as well as the caliber of the vessel being wider, fluid is now shifting out of the vessel at a much greater rate as well. So it's this thing called third spacing. Basically, your interstitial space grows, your interstitial fluid grows. So all this fluid that was once in the blood vessel is now being pushed out into the periphery, and as well as being pushed into the periphery, the caliber of the vessels is widening. Both of these contribute to this drop in blood pressure. And the permeability thing is really important because if it was purely vasodilation, you could just give a couple of liters of fluid and that person's blood pressure should respond. In septic shock, this increased vascular permeability means that every time you put a liter of fluid in, something like 70% of it just shifts straight back out into that interstitial space. And so you keep pumping them full of fluid, but very little fluid is actually staying in here where it needs to be in order to raise the blood pressure. Most of it is moving into the peripheries and causing edema, so it causes edema, and that can be pulmonary edema. It causes pleural edema, essentially. Trying to think of the proper word. Pleural effusion, sorry. A pleural effusion. It can also cause pericardial effusions. Basically, all of your membranes start secreting all this fluid because there's now nothing holding it in the blood. And that causes their blood pressure to drop, means that they don't respond very well to fluid. And if you keep loading them up with liters and liters and liters of fluid, all it's doing is moving into these spaces where in this case it's going to affect breathing. And in this case, it's going to affect your cardiac output. So by overloading them with fluid, you're actually going to make them much sicker and you can kill them. So another area in sepsis, it's a very interesting area to read up on, but this idea of using too much fluids is gaining a lot of traction, and current guidelines are changing in the management of sepsis in terms of fluid resuscitation. Cool. That's sepsis. The others will be quicker than that. Next is hemorrhagic. Hemorrhagic is a bit of an easy one to kind of envision. Hemorrhagic just means bleeding. The person's gone into shock. They've lost their blood pressure. They've lost their ability to perfuse their end organs because there's no longer any blood left in the system. So in this case, it's not an issue of these being too wide. What the issue is that there's actually just not enough fluid in the system anymore. So say you used to have, let's say, 8 liters going around, and then you lost 3 liters of your blood. You've lost over a third of your blood supply, nearly half. And what's going to happen is that you've just got less blood that's floating through the system. So you've got less blood in order to fill up this tank. Less blood's going to get to the end organs, and that's what causes the shock. When you're seeing a trauma patient and you're querying hemorrhagic shock, the rule is on the floor plus 4 more. So these are basically the places into which you can bleed. So they could have an external wound and be bleeding all over the bed, all over the floor, anything like that. The 4 more are the abdomen, the pelvis, the thorax, and long bones. These are all compartments in which you can lose liters and liters of blood before any kind of tamponade or compression starts to compress the bleeding and it's getting it to stop. So your abdomen, you can lose liters of blood into. Your pelvis is separated from your abdomen because typically different etiologies and things. So pelvic fractures can sever iliac vessels, both veins and arteries, and cause massive blood loss. The thorax, bleeding into the chest, is a double whammy because as well as losing blood, you're also losing respiratory capacity because you're filling up your lung space with blood. And long bones is the one that a lot of people forget about. A fractured femur, you can lose liters of blood into the area, into the fascia. So this is one of the reasons why in a trauma patient, the first thing that if you see a displaced fracture, even if it's not compounded, so even if it's not poking through the skin, a displaced fracture needs to be kind of realigned as quickly as possible. So you do your standard ABCDs. And if it becomes obvious in C that you're losing blood through a long bone fracture, it should be a priority to realign that under traction in order to prevent the loss of blood into that area. Really important, especially when you think, so bones themselves are incredibly vascular, but also in some cases, so for example, the femur, you do actually have your femoral vessels which run quite close to the bone and can be sheared in an accident. So long bones, very, very vascular structures, but also run close to vessels. This kind of thing, this applies not just in trauma, but any patient in which you see hypotension and the signs of shock. One of the things you should look for, because they could have had a major gastrointestinal bleed, which kind of comes under abdo. So either they can be bleeding into their peritoneal cavity, or they can be bleeding into a viscus, such as the stomach. Bleeding into the peritoneal cavity, by the way, things important to keep in mind are your spleen and your liver, especially in rib fractures, because these guys actually sit up underneath the rib cage. So if you remember if we draw your rib cage just like this is your rib cage. Your liver actually, the edge just sticks out, but it actually sits up under here. Your spleen sits up under here. So you fracture any of these ribs down here, you can potentially break and damage the liver or the spleen and cause massive bleeding. The kidneys are another one. I was going to say renal, kidneys. That's hemorrhagic. The third is obstructive. Things to know for this one are a PE, a massive PE. So this is like a saddle embolus. Sorry, PE being pulmonary embolism. Saddle embolus, a tamponade, a cardiac tamponade, or finally a tension pneumothorax. So if we go back to this diagram, obstructive shock means that you've got something that's blocking the pipes up, right? So you've got this, usually the flow is like this, but in a massive pulmonary embolus, like a saddle embolus, or in a tension pneumothorax, or in a tamponade, what you're doing is somewhere in this area here, you're blocking the pipe. So all this blood starts backing up, and the blood can't get through here. So if you're not getting blood through here, there's suddenly no blood in this system, and there's nothing perfusing your end organs. So obstructive shock can kill incredibly quickly. It is definitely an emergency, and the management of an obstructive shock is to immediately remove whatever is causing the obstruction. So you need to do a pericardiocentesis, you need to do a finger thoracostomy, you need to basically, saddle embolus, the management is very complicated, but you need to dissolve or retrieve the clot, or get that patient on ECMO essentially as quickly as you can. So these very, very quickly evolving. So tension pneumothorax and tamponade, they can theoretically kill within minutes if they're rapidly evolving. So very, very important causes of obstructive shock to know of. I'll quickly run through as well, because just with these three, you basically see the three different presentations of shock in terms of how you see the patient. So in all cases of shock, you'll see the low blood pressure or the hypotension. You'll see the increased heart rate. You'll usually see an increased rest rate. These signs are kind of like, they're what you'll see in every case of shock, because these are the things that are implying end organ perfusion. But clinically, there are some differences. So in distributive shock, so including sepsis, anaphylaxis, neurogenic, but especially sepsis, what you'll see is the patient is warm and clammy and sweaty and red. Basically, they're completely vasodilated, right? And it's the same as if that you've just gone for a run on a 40°C day. You're going to be hot and sweaty because you get vasodilation in the skin. It's the same with these guys. These guys have got profound vasodilation, so they are warm, clammy, sweaty, and red. That's very, very, very different to what you see in hemorrhagic shock. These guys, they're peripherally shut down. Why? Because what's happening is that you've got this, you're used to having a vessel like this with blood running through. We then go to a picture, say like this, where you've now got this tiny amount of blood going through. So to try and maintain your blood pressure, it tries to keep the ratio of blood to volume of the vessel moderately similar so that your pressure stays the same. So what happens is you become massively vasoconstricted so that the space of the arrow remains in the same kind of ratio as the space of the arrows here. So you peripherally shut down, you clamp down everything. So these guys are freezing cold, perishingly cold hands. They're also pale. And they look really sick. So they're cold and they're pale as opposed to warm, flushed, sweaty. The key giveaway with obstructive shock, the key thing to keep in mind that kind of distinguishes it from all the other guys is you get bulging neck vessels. Why is that? So if this is a person, that's their head. Terrifying, I know. And their heart sits here, right? Let's draw it as an actual heart. If this is like your right atrium, you've got your superior vena cava and your inferior vena cava, and they both enter and drain into the right atrium, right? And the right atrium pumps it through the right ventricle and out to the pulmonary system. Let's say that this person had a massive PE, right? So this is their pulmonary vessels, and they've got this massive clot here. Suddenly, all this blood starts backing up. And as it backs up here, it backs up along the pathway, and it fills all this up. And the thing with veins is that, remember, arteries have got a thick muscular wall. Veins, they're mainly elastin. They're very, very elastic. So what they do is they swell to accompany or accommodate the blood. So all this blood that should be going out, all this blood that should be leaving the venous system and going into the arterial system can no longer do that. So it's backing up in the venous system. And the way that we can see that clinically is that this person's neck vessels go from maybe very faint to see. They become very, very, very engorged. Think like John Cena during a wrestling match, or someone that's really like those stereotypical pictures of the people that are really, really angry, clenching their jaw, and all their veins pop out really thick. That's the kind of picture that you see. So they get a markedly raised JVP, jugular venous pressure. There's a thing that we talk about, like the wriggling earlobe, which is a sign that your JVP is actually so high that each time your heart pumps, it jiggles the earlobe. Of course, you need to be careful that you're not just seeing a patient in congestive heart failure, which like a chronic congestive heart failure. You've got to make sure that this is an acute presentation and that they have all these other things going on, such as the hypotension and the respirate and all that kind of stuff. Anyway, this is the distinguishing feature for obstructive versus other kinds of shock, because in the other kinds of shock, you've got low blood pressure everywhere, right? So the low blood pressure everywhere means that there's actually not a whole lot of blood in the venous system. If if I get rid of all this, there's not a lot of blood in the venous system because the heart is pumping as much as it can into the arterial system in order to try and make it full so that it can supply the end organs. Cool. So obstructive, bulging neck vessels, things to think of are a massive PE, a tamponade, and a tension pneumothorax. And I'll quickly explain tamponade. So tension pneumothorax is a pneumothorax that every time you breathe in, you increase the pressure in the pneumothorax and it starts pushing everything away. So in that, if you did a chest x-ray, which you shouldn't, you should just treat empirically, but if you did a chest x-ray, they would have mediastinal shift. And clinically, they'll have a deviated trachea, as well as absent breath sounds on the side that the pneumothorax is, because the, so if this is like your pleura, you've got this, the pleura here, this is the tension pneumothorax, it starts expanding and collapsing the lung down around it. So this, all this area starts becoming tension pneumothorax. That's all the tension pneumothorax, and it keeps growing and growing and growing, and that's why you get, it kind of pushes your heart out of the way and it deviates your trachea because suddenly you've got increased pressures. So because that they have deviated trachea, no breath sounds in this area, and all the signs of shock that we just talked about. Tamponade, what happens in tamponade is you get diastolic failure. So if this is your heart, it's surrounded by the pericardium, and usually the gap isn't that big. It's usually very tightly wrapped around. Now, you got 4 chambers in the heart: right atrium, right ventricle, left atrium, left ventricle. Your right side of the heart is low pressure, left side of the heart is high pressure. Tamponade, you've got something filling up this pericardial space, whether that's blood or it's fluid. And that can happen because you got stabbed in the heart, you've got pericarditis, anything like that. You've had a massive heart attack and ruptured your ventricular wall. But anyway, you've got this increasing pressure in here, and because you've got a fibrous capsule surrounding the heart, so the capsule can't expand, so it has to expand inwards. And as the hematoma or the fluid grows, the thing that's going to give way first is the low pressure system. So the first thing that we see is the right ventricle buckling, particularly in diastole and then in systole. This is an issue because eventually what happens is it buckles so much during diastole that it can't actually fill up with blood. And so if your right ventricle doesn't fill up with blood, then there's nothing going through to the left atrium. So nothing's going out to the rest of the body. And it also means that your blood starts backing up in your right atrium and then back out into the veins, same as before. So the way you do that, you drain this, is you stick a needle in and you suck whatever is causing the tamponade out to allow the right ventricle to fill up with blood again and keep pumping so that you remove the obstructive shock. Cool. Subtle embolus we already kind of talked about. That's obstructive. Then we have cardiogenic. Cardiogenic is something like cardiac arrest or a massive heart attack. Let's say AMI. Something like that. Basically, you've stuffed up the pump. So going back to, where is it? This diagram again. In this case, you've blocked the heart. The heart is the pump. You're not pumping anything properly, so there's no blood getting through to your arterial system. It's all kind of banking up in your ventricular system again, but it's under less high pressure because the thing that causes the pressure in obstructive is something's blocking the pipe and we're actually pushing kind of blood out against force. In cardiogenic, you see less of that big kind of swollen vessel kind of picture. Cardiogenic. Anaphylaxis. Basically, the exact same mechanism as sepsis. It's dysregulated immune response, but it's aseptic. So it's not because of an infection, rather it's due to an allergic response usually. For a true anaphylaxis, there's pseudo-anaphylaxis, which isn't an allergic response. But when we talk about anaphylaxis, we're talking about dysregulated immune response due to allergy, resulting in the systemic release of histamine, and that results in the vasodilation and the permeability. So it's just another form of distributive shock. Vasopermeability. Cool. Anaphylaxis. Last one, neurogenic. Neurogenic. This is your spinal cord maintains tone. And by tone, we're talking about arterial tone. So your vessel tone is maintained by signals from the spinal cord. If we block the spinal cord, then we lose the tone and you get arterial vasodilation. So again, it's just another form of distributive shock. In this case, this can be a spinal injury, or we can induce it with nerve blocks. So when we give someone an epidural, we actually expect their blood pressure to drop a little bit because we know that it's going to affect down below. It does depend on what level you do it at. So if you remember your sympathetic nervous system, and let's do a different color, parasympathetic nervous system. Parasympathetic is cranial and caudal, and sympathetic is thoracolumbar. So your sympathetic nervous system is thoracolumbar. That's what maintains the tone. And so if you go up a little bit too high and impair too much of the thoracolumbar kind of ganglia, then you can develop this spinal shock, this neurogenic shock. This one, it's probably a little bit rare, but you do see sometimes with an epidural, you can see a small drop in the blood pressure. And obviously that results in the baroreceptor reflex, which is why you get the increase in heart rate. Okay. That was a big shoot. So just as a quick recap, sepsis means poor end organ perfusion, usually because you've got low blood pressure, which tries to be compensated with a high heart rate, and you also get an increased resp rate. Remember SHOCAN as the different types of shock. Sepsis, anaphylaxis, and neurogenic shock go into this other class called distributive shocks. In distributive shock, you've got vasodilation and increased vasopermeability, which means that you've got a bigger volume in which your blood has to fill, and that's why your blood pressure drops, and you also lose fluid into the peripheries. Hemorrhagic is simple. You're just losing blood because you're bleeding. Remember, 4 on the floor plus 4 more as the places to look for bleeding: the floor, the abdomen, pelvis, thorax, and long bones. Obstructive shock includes things like PE, tamponade, and a tension pneumothorax. Look for the bulging neck vessels. Cardiogenic is due to like severe cardiac failure, a cardiac arrest, massive AMI. The reason you're not perfusing is because your heart isn't pumping. Anaphylaxis is a dysregulated immune response, another form of distributive. Neurogenic, another form of distributive. Thanks very much for bearing with me for this incredibly long shoot. I hope it's been useful, and I will put the timestamps in the bottom of the video that say when I talk about each different type of shock. If you've got any feedback, please let me know. Also, remember to check out our new website, medtutes.wordpress.com. You'll find a whole bunch more information on there, a lot of resources, and it'll also link you through to Drug Bites, which is the new podcast by MedTutes looking at pharmacology. So I'd really encourage you to check that out as well. And if you've enjoyed the show, or if you've enjoyed the shoot, please subscribe and like the video and give us your feedback. Thanks very much.